So we saw a case of dilated ureter, which Dr. Tan showed a couple of weeks back, and distally, there was no obstructing thing, and the ureter had some mural calcification. So I found a 1998 RSNA article which speaks about calcification in the ureteral wall. It's uncommon, and it's usually when seen, it is usually seen with infective conditions like schistosoma and TB, and it can also be caused by amyloid. So just as a
So you really have just like two differential then, right? Or I guess, yeah, amyloid, schisto, or TB.
yeah.
So it's pretty specific. Like it narrows the
And wasn't yours
differential.
amyloid?
Yes.
Nice. I have seen urothelial cancers in the bladder occasionally calcify. I've never seen it in the ureter.
Yes.
Okay, cool. Thank you.
So this case is just a normal vascular variant. So what do we see here?
Can you scroll down?
Replaced or accessory left hepatic artery arising from the left gastric in the ligamentum venosum.
Perfect. So each time I see a vessel here at the ligamentum venosum, I know it is either replaced or accessory left hepatic artery. If I go further inferiorly, that's the portal vein, that's the IVC, and I see a vessel coursing through the portocaval space. So usually it's a space which is not much used. Occasionally we see lymph node, no, very often we see lymph nodes here, but other than lymph nodes, we don't see anything else there. So if we see a vessel there, it is some variation of the right hepatic artery, either arising directly from the celiac, as in this case, or if you see a vessel here, it is again either replaced or accessory right hepatic arising from SMA. This is something like, I'm surprised I just got to know very recently. Did I lose you guys?
Yeah, no.
No, we're here.
I'm just following that vessel because it looks like one of the branches of the left hepatic artery might also be coming from it. Yeah, right there. Do you see that tiny little dot?
This one?
No. Sorry. From the replaced right hepatic artery, there's also a little branch going to the left lobe as well.
Yes.
Right there. Yes, that
Yep,
one.
there it is.
Yeah.
So that means that it's kind of actually a replaced common hepatic artery rising from SMA and then an accessory left hepatic from the left gastric.
Yes.
Nice. Supposed to be about 25% of patients have this.
I don't know the percentage.
I think for a replaced right is around there.
I was very excited about knowing this space in particular.
Cool. It's this is particularly important if they're going to be doing any catheter embolization, and then also pancreatic cancer cases where they might have celiac axis involvement. And but if they have a replaced right hepatic artery arising from the SMA, they can possibly do an Appleby procedure. So those are a couple of times when it's really important.
Yes.
Okay.
Ovarian hyperstimulation syndrome.
Yes, of course. Yes, excellent job. So we have bilateral enlarged ovaries with multiple follicles. And what Golan stage would it be?
That I'm not sure.
I just learned about this, so don't worry. Okay, I'm just going to bring it over here. So ovarian hyperstimulation syndrome, this patient had actually undergone egg retrieval. They were going through egg freezing a couple of days prior. And what we're looking for like the degree of severity. So some of the symptoms can be bloating, and then phleretic chest pain. And this patient actually had both of those things, and third spacing of fluid. So basically the hyperstimulated follicles, the corpus lutea here, secrete a kind of vasogenic enzyme that causes third spacing. So you can get, so in this case, for example, we have a little small volume ascites, and then we also even have a little bit of fluid between the liver and the diaphragm. And we thought that's actually why they were having pleuritic chest pain, and then a little bit of perisplenic fluid. So this is kind of a milder case. This is the staging system that takes into account clinical symptoms and some of the imaging findings. So our patient's ovaries were 8 centimeters, so it would be grade 2. They had some nausea and enlarged ovaries, and then they did have a little bit of ascites. So it was like basically between a grade 2 and a grade 3. All of these milder, moderate ones are usually just treated conservatively with pain management. But when it gets really severe, they can actually get anemic, they can have coagulation abnormalities, renal abnormalities, and these patients might need to be admitted with, high vigilance on their renal function. So yeah, that was ovarian. And actually, hold on, my residents were asking me, I was showing them the case, and they said, how do we know it's not a tube ovarian abscess? So I just wanted to show a couple of other things. So this is example of a tube ovarian abscess where you have more thick-walled, irregular spaces and more inflammation and like thickening of the walls and inflammation around it. And then also torsion is usually not bilateral, but it can have an enlarged ovary. Usually has these peripheralized follicles rather than, multiple kind of same-sized follicles throughout the ovary.
Cool.
This is a patient who has a known diagnosis and then got the MRI for staging.
Rectal cancer.
Cervical cancer. Is that what you said?
Cervical. No, I didn't say cervical, but yeah, I saw some mass.
Where? In the cervix.
If you go on sagittal.
Yeah, evil gray of the cervix that's causing severe obstruction and like fluid retention in the markedly dilated endometrium.
Yes. So this is the T1 fat sag. Go ahead.
So a lot of blood in there in the endometrium.
Yep, perfect. So let me go back to the, so here it is, and there's a malignant obstruction from the cervical cancer. This one measured 4 centimeters, and then there was evidence of perimetrial invasion. Maybe here it's a little bit blurred. I think you lose the T2 dark perimetrium along the right lateral aspect. So it's at least a T2B, if not over. And then the patient underwent radiation planning. Let me see if I can pull up that radiation planning MR. There it is. You can see it, right? Yeah. And so then we have a template for this to make sure that it's appropriately positioned, and then the patient had treatment and had resolution of the obstruction, and then decrease in size of the primary cervical malignancy. So what I learned is there's been an update to the cervical cancer staging, NCCN. There's an update from April, and then the FIGO staging from 2018. You divide it by size. So if it's less than 2 centimeters, 2 to 4, or over 4 centimeters, this was kind of borderline, close to 4 and over 4. So definitely chemoradiation is the option. In patients with early stage cervical cancer, so less than 2 centimeters, they actually have an option for fertility sparing, which is really great. I think I showed a case of that before. So if it's 2 centimeters or less, they can treat it with first they need MR. So that's what the NCCN April 24-25 update shows, which is consistent with the FIGO recommendation. Is now they require MR, especially for early stage cervical cancer, to see if they're appropriate candidates for fertility sparing. The other imaging modality that is now like very deeply embedded into cervical cancer staging is PET-CT for advanced stage, looking primarily for nodal and distant metastasis. So for early stage cervical cancer, if it's less than 2 centimeters and there's no perimetrial invasion, then they can they can conization, where they just kind of cut around the area of the tumor, and then provide fertility for the patient. And then those that undergo that, they then basically get Q6-month MR surveillance imaging indefinitely to ensure that there's no residual tumor or recurrence. In this case, this was not amenable to kind of local options. So the patient underwent chemoradiation and responded very well to it, and then they get follow-up imaging, MR, and PET-CT for surveillance imaging. So we don't see cervical cancer often because it's primarily a third world disease. 85% of cervical cancer happen in third world countries. But for the ones that do occur in the US, MR and PET-CT are now an integral part of both staging and assessment after therapy.
Excellent review. I just have a comment when you were talking about the new staging, the 4 centimeter thing. That makes sense to me because most of cervical cancer is squamous cell. So like 90% is squamous cell, like 10% is adenocarcinoma. So that's why squamous cells in general tend to respond well to chemoradiation, just like anal cancer, anal squamous cell. Often they just do definitive chemoradiation. And same thing with anal cancer. Squamous cell, the size is what changes the stage. So
oh yeah, that makes sense. Yeah, go ahead.
A different template for the anal cancer because that squamous cell thing, they're going to treat it differently with chemorads and just definitive chemorads, and then also the size is what changes the stage. And I think it's like 2 to 5 centimeters, and then above 5 centimeters for anal.
In cervical cancer, in addition to the size, one of the other factors is stromal invasion that changes the staging. So it's a combination of size as well as the invasion, extent of invasion to the stroma. For early stage, that's done pathologically when they do the biopsy. But now, like our gynecologists are leaning more to MR to kind of assess the stromal invasion. If it's less than 50% stromal invasion or more than 50% stromal invasion, which has prognostic implication for the patients.
Cool. Yeah. Remember you showed us that case of the small one?
Oh yes, and that's right. And my gynec provider was asking for the stromal invasion, and that's not part of our SAR template for cervical cancer to report the stromal invasion. So I was like looking into this, and that's when I realized because of that update with now looking at stromal invasion, I think our gynecologists are not only expecting path staging the stromal invasion, but now and rightly so, we can see it on MR. And even though it's not really embedded in our templates yet to define the extent of stromal invasion. And I think a good way to do that is just give the percentage, because I think the depth can be a little bit skewed. So what I do now is I give the depth of it, and then I give the depth of the cervical stroma, so that they can see if it's like 50% or microscopically. The measurement they use is like if it's 4 millimeters or less. But on MR, I think it's very hard for us to get to that millimeter level. So I think giving a relative percentage can be very helpful in place.
Nice. And then one other comment is that you had said that like it's less common here than in other countries. And I think one factor might be that a lot of people now get the HPV vaccine, Gardasil.
Yes, it's totally preventable, right? With the vaccine.
Yeah. And supposedly it has reduced the risk of malignancy by 90%. So it's an HPV vaccine recommended for individuals 9 to 45 years old. Yeah. So anyway.
And even pap smear.
Yep.
And pap smears. Yep. Mm-hmm.
Like this is one of those things where population health efforts can like completely change the prognosis, of the patient. So preventable things like vaccine and pap smears, just screening, right? And then treatment, like even just early treatment of the dysplastic changes can be curative.
Yep.
So if you guys can focus on the pancreas.
Annular pancreas. I see some tissue like going
Yeah.
toward,
That's the duodenum.
yeah. And then right there, is there like some pancreatic tissue that went up towards it? Right. Yeah, like,
So pancreas is annular, but it is around the portal vein.
no, go down. And then right there, like, see, there's like a lobule of tissue. Yeah, if you go up from there, it's like growing towards the duodenum. It doesn't sound like you think that that's the.
Like maybe
I'm wondering,
incomplete around the duodenum.
Maybe incomplete variant.
Yeah.
Yeah. But complete around the portal.
Yeah. So at times, like, you have this lobulation and I don't know, like, do you guys call it? Like, I do not call it unless like I see some upstream obstruction, or if I see the crocodile jaw morphology and I can pull that paper, what I mean. That's the paper by Kumar at Mayo. So he has described, I think, 5 or 6 types of partial annular pancreas. So, and the reason I was showing this was this pancreas was completely encircling the portal vein, also known as circumportal or porcine pancreas, because it was first discovered in pigs. I don't know if there is any importance to this, any surgical importance to this.
Interesting. I have never seen that. But I'm wondering if, like, the same way with annular pancreas, like if they're going to be doing pancreatic surgery, there could be like ducts that are wrapping around. So it could make things like a Whipple more complicated, or.
I think so, yeah. So that's the annular pancreas in adults that I was talking about. And
Yeah, I recently learned about this crocodile jaw sign.
Oh yeah, look at that. Looks like a crocodile.
so if I see that, then I raise a possibility. But I agree, like, if I see some just tissue, pancreatic tissue just touching, which is extra and looks other than the pancreatic head, I don't know. Like, do you guys mention that as partial?
No, I like what you're saying, like only if there's real symptoms or concerned about it. But the partial thing I think is interesting because, like, yeah, you don't always see the tissue going around. Sometimes it's like a fibrotic band.
Mm-hmm.
But if they do have the symptoms and like there's a caliber change there, then I do bring that up.
Okay.
And actually, in this article, if you scroll up, it was showing like that the duct can wrap around it. So it can make, you can't just like cut the band or if you keep scrolling up, I think there was an ERCP that you went past. Right there, the ERCP on figure 2B, like you can see that the duct is wrapping around. So it can be tricky because it can have alternate drainage pathways. It can lead to pancreatitis, and you can't just, release the tissue because you could cut through that pancreatic duct.
Mm-hmm.
Nice. So this is a thyroid. What do you guys think about this lesion? Do you like it? You don't like it?
That is solid. So 2, hypoechoic 2.
Margins. Oh.
So it's at least thyroid's 4. What's the size? More than 1.5. So it goes for FNA.
Yeah, exactly. So we gave this solid hypoechoic, irregular margins, taller than wide, and with microcalcs. So 12 points went for FNA, and this was a papillary thyroid cancer. So I just thought I would show it. I feel like it's a good example of like the irregular margins, hypoechogenicity. This is a pretty typical look for papillary. Papillary thyroid cancers are about 85 to 90% of thyroid malignancies. They have a female predominance, usually in the 30s to 40-year-old decade. They tend to be solitary with these irregular margins, microcalcifications from psammoma bodies. And they can also give you cystic necrotic lymph nodes. So often the ipsilateral cervical lymph nodes will be involved, and they may preemptively resect those during surgery. So I just thought it was a nice example of a thyroid cancer, since we do a lot of thyroid ultrasound here, and we see a lot of spongy nodules, but this is what we're looking for. And these actually have a really good long-term prognosis. I think it's like 90% 5-year survival. So they're pretty good long-term survival.
So I just looked in the internet, and as Dr. Sekhar mentioned about the importance of circumportal pancreas, it does have an impact on the surgery during pancreaticoduodenectomy because it requires additional dissection around the fused pancreatic tissue. Thank you.
Nice, thanks. I will look for it now. I don't think I've ever described that. Circumportal pancreas.
In fact, like, we have a research lab here, and I reached out to one of those research people and I said, like, you do a lot of scans for pigs. Why don't you send me a pig, like the scan of a pig? And that particular pig did not have circumportal, because I was like, I would show that also. That would be cool.
Oh. So it's not every pig that has it.
Yeah.
Cool.
I'm pulling up a case, but I'm not ready.
Okay. Okay, so focus on the pancreas.
There's something there at the head.
So,
Yes. There is a hypoenhancing round mass in the head of the pancreas.
But there's not a lot of dill.
Mm.
Well, maybe just, I
The
don't know.
pancreatic duct
Yeah.
is going right by it. So that is
Yeah.
unusual for like an adeno.
Yeah.
And then there's also some findings in the tail.
Well, it's a little bit hypoenhancing.
There's actually this little hypervascular mass.
Oh, I thought that was a
vessel.
that was like a vessel. I'm like splenic.
And
Yeah.
there is this. So what do you think about those?
neuroendocrine.
Yeah. Okay. So those
How
are
does that explain the head though?
yeah. So, okay. 3 different findings. 2 look like neuroendocrine. 1 is, indeterminate. That could have even been a SPEN or neuroendocrine or whatever. So this patient actually has symptomatic hypoglycemia. So we're like, okay, what do? We don't know which one of these is the, insulinoma. We don't know what this is. Okay. And I'll just tell you, looking through the liver, didn't see that much. We did see this little nodule here. Could be a met, not sure. Okay. So they go for dotatate. And there are several lesions that we did not see on CT, which is why dotatate is amazing. Multiple things lighting up in the pancreas.
Oh my gosh, that one's also lights up.
And then both of the tail lesions, and then multiple lymph nodes that were not enlarged, but were bright on dotatate. So basically, this is metastatic neuroendocrine that has both lymphadenopathy and liver mets, which we really underestimated on the CT scan. So then they said, okay, there's multiple, and the main problem this patient is having is symptomatic hypoglycemia. So they're like, okay, they have multiple neuroendocrines in the pancreas. Which one is the insulinoma? So they go and biopsy the head one, and they stain it for insulin receptors, and it did not stain positive. So this was not the insulinoma. But they did not biopsy these 2. So then they decided to go do a calcium stim test, which is an IR exam where basically they inject calcium into like the splenic artery, the SMA, celiac axis, pancreatic duodenal, hepatic artery, etc. And then they record the insulin level from the hepatic veins. And they see which area, when they stimulated it with calcium, it ended up secreting insulin. And anyway, in the end, basically came from the body tail area. When they injected the splenic artery, that's when they got the insulin secretion. So our very talented endoscopist went and ablated those 2 tiny tail lesions.
Oh, wow.
Yep. So they're now doing EUS ablation. I showed you guys a case of one of these recently. But anyway, and then this is the post scan. So it's really hard to see, but we basically felt that there was non-enhancement, where there previously was that really avidly enhancing nodule. And then the other one also looked like a little black hole. So
I'm sorry, it's transgastric, and then they just put like a ablation probe.
Yeah, he went and did like ablation times 8 of like each of these little nodules.
Wow.
Yeah, I showed a case recently too of like a bigger one that my endoscopist also ablated endoscopically. So it's happening.
And how do they choose which candidates are appropriate for ablation versus enucleation?
They decided, well, this one, because they have Mets, they have
yeah.
lesions, and these were the insulinomas. Based on the calcium stim test, they decided that they would treat them with ablation.
But like if you had a de novo, like just a new patient who was asymptomatic, had a small neuroendocrine tumor that they wanted to reset, like
if they're asymptomatic with a small neuroendocrine less than a centimeter, there's actually evidence that you can do active surveillance on those patients. But I see your question, like if you are going to intervene, when do you choose ablation versus enucleation? And I'm not sure about that at this point. I will ask my endoscopist.
Can I say something?
Mm-hmm.
Now, in hindsight, at least even the head mass did not look more like adenocarcinoma, because I think, as we did discuss like a couple of weeks back, adeno comes from the duct. So the first thing it does is ductal dilation. So with that bigger mass, there was very tiny bit of ductal dilation. So Mets, even if they're big, they do not cause as much ductal dilation. Like that's a relative thing. So
yeah, I totally agree. It didn't, and it looked so round, like it didn't to me look like an adeno. I would have thought maybe neuroendocrine, or, just like a little atypical because it doesn't have the arterial enhancement, but neuroendocrine can do that, especially as they get larger. So I definitely, that's a really good point. I don't think it looked like a typical adeno. But this whole thing about like which one is the insulinoma was very interesting to me, because it's like then they ended up going down the calcium stim test and and it wasn't the big one, it was like those little ones. So it was interesting.
So did it address the hypoglycemia after the ablation?
Yep. No longer symptomatically hypoglycemic, and they can be very, very symptomatic, like passing out kind of thing. So it's, yeah, definitely debilitating. Okay, so this is a scan for elevated HCG. It was 2,500. So this is the uterus. So by 2,500, what should we see?
we should see the yolk sac.
Yeah, exactly. So 1,500 to 2,000, you should see a gestational sac. And then by 2,500, you should probably see a yolk sac. So we're not seeing anything in the endometrial cavity. And then this is the right adnexa with a lot of question marks. Looking like this.
Mm.
And
Is there
then
flow? Oh,
yeah, a little, I don't know, but there's all this stuff too. And then this
yeah.
left ovary with surrounded by all this stuff. So this is where I think this is all actually hemoperitoneum, and it can be really tricky if you're not like looking for it, or if it, it doesn't look like a ton of fluid, it looks very complex. But anyway, this was,
I think I saw the gestational sac in the last image you showed.
yeah, we weren't sure if like maybe there's a little
Yeah.
thingy. Most of it is, that's the uterus, and then all this heterogeneity all wrapping around the uterus with like a kind of right adnexal mass. So anyway, we called this concerning for a ruptured ectopic with hemoperitoneum. They went to the operating room, and that's what it was. It was a large ectopic in the right isthmus fallopian tube with
Wow.
1,500 mLs of hemoperitoneum. So anytime you see like, the HCG is that high, you don't have an intrauterine pregnancy, look very carefully for blood. And if you see blood, then that's basically a ruptured ectopic until proven otherwise. And then, as you guys know, there's that radiology paper with like the new lexicon for first trimester. So we use terms like early pregnancy loss rather than abortion or, miscarriage and things like that. So.
And also radiology literature prefers term CSEP, cervical scar ectopic pregnancy, over CSP, cervical scar pregnancy, because of a lawsuit recently. This was, I think, 2024 radiographics paper.
Wait, what was the lawsuit about?
I mean, over the terminology, like, CSP can be even like, they said like CSP is not being considered as a something which is alarming. So use the term, it is ectopic, but use the term, use E instead of CSP.
Hmm. This is a patient who's been getting surveillance imaging for IPMNs. There's several IPMNs. Let me show you the coronal, and then some of them have branch duct communication. So like this one has a nice branch duct communication. Maybe this one as well. Yeah, there's a few that has branch duct communication that you can follow. I'm showing this because the duct is getting a little bit bigger. So it's still like only 3 millimeters, I think, 3 or 4 millimeters, but it was like 2 before. So it's just getting a little bit larger, like in the body, for example. So I'm showing this because of this great paper that I saw about the different types of IPMN. So this is papers in this journal, and they have a really great cartoon diagram. So this is, some of the IPMNs look like this, and it has a nice branch duct communications. The pancreatic duct is normal in caliber. So that's your typical branch duct. And then you've got the main duct where there's not the, clustered grapefruit IPMNs, and the duct is just dilated abnormally. And so that's your main duct IPMN. And what I learned is you can get segmental main duct IPM, which is so you just get segmental dilatation and kind of worrisome findings without involving the whole duct. And then you get mixed duct IPMN, where you get both the branch duct IPMNs and then the main duct is also dilated. And the prognosis for this is somewhere between a main duct and a branch duct. So I think this is probably coming to become like a branch duct IPMN, but it's not, I don't know if there's a threshold to call it a branch duct, but the pancreatic duct is just becoming a little bit larger over the serial follow-up imaging for the cystic findings. And I don't think it's enough to warrant an EUS yet, so I would just recommend a surveillance imaging, continue surveillance imaging.
I think I remember reading that, if the ductal dimension is more than 1 centimeter, which is 10 millimeter, it is definitely concerning. Between 5 millimeter to 9 millimeter, it is concerning.
Yeah, so that's the Kyoto guidelines, which is like the update of the Fukuoka guidelines. But basically there are worrisome features and then there's high risk stigmata of malignancy. Worrisome features is 5 to 9 millimeter duct dilation, and the high risk stigmata is greater than a centimeter. There's a bunch of other factors too. So the other worrisome features are like an enhancing nodule. I think that's like less than 5 millimeters, size greater than 3 centimeters of the overall IPMN. Pancreatitis, that was a new one. So, that kind of triggers you to like, oh, there might be a more concerning component. And then for the high risk stigmata is like a true enhancing nodular component, and then the main duct dilation.
I'm not sure if let me see. There are the features that you mentioned that's below the cartoon diagram. I'm not sure if this is aligning with the new Fukuoka guidelines or not. Oh, actually, this one's for yeah, this is still an old version of this.
Exactly. That's the Fukuoka one, and then the new one is called Kyoto. There's just a couple of things they added.
Yeah, like this one doesn't have the pancreatitis component yet.
Yeah, which actually I was just discussing that with somebody, because we've seen now multiple cases where it looks like pancreatitis, but the reason for the pancreatitis is that there was an underlying neoplasm. So I'm now like much more suspicious that the patient like doesn't have this good alcohol, like gallstone pancreatitis history, or there's anything weird looking about it. You should get a follow-up, make sure that there's no underlying mass. And then especially distal pancreatitis, if it's isolated distal pancreatitis, there was a paper in AJR last year saying that has a very much higher rate of having an underlying cancer.
As you're talking about this, it makes me think about a case that came for second opinion, and the patient had recurrent episodes of pancreatitis. The patient did have sludge, but also had recurrent, like gallbladder sludge and stuff like that, but had persistent recurrent pancreatitis, and got MR. It didn't, kind of underwhelming, but the quality of the MR was kind of not optimal. CT, and then later got diagnosed with pancreatic cancer.
Yep. Yeah.
But it was already advanced by that time, so it was unresectable.
Mm.
And kind of, just kind of supporting what you were just saying, like you have to find a reason, right? And make sure that it resolves. And if there's recurrence, there's no clear etiology, I think, EUS or something more than just imaging will be needed.
And any abrupt duct transition, be concerned about an occult thing. And actually our EUS guys will go in and biopsy around the area of transition. Even if they don't see a mass, they'll just like biopsy around that area to see if there's an occult mass.
Yeah, there was a paper that was published in Abdominal Radiology for that pancreatic duct abrupt cutoff sign, and 50% harbored cancer. The other 50% was from stricture from pancreatitis.
Yeah. Cool.
So as we know that main duct IPMN need not necessarily involve the entire duct, it can be just along a particular segment as well. So we have this different entity as a differential, like how we have choledococele and Santorini cele. We can have dilation of just the distal part of, just the proximal part of the duct of Wirsing, also known as Wirsingocele. I'm not sure how do we differentiate it from the main duct IPMN. Maybe the age could be a factor, but I guess ultimate diagnosis lies with like ERCP only.
And this looks very like smooth and not like too engorged, right? And with no other IPMNs.
Yeah.
Sometimes I've noticed like the main duct is a little bit larger than the body and tail. I don't I think sometimes it's normal to just have a little bit more prominent main duct at the head.
Agree.
And
but
still
this
be normal.
Wirsingocele is actually how I met Yashant.
What?
Yeah.
Yes.
Remember I gave a pancreas talk and afterwards he came running up and he's like, I have a companion case for you, a Wirsingocele. And then he emailed me, followed through. It was awesome. The beginning of a beautiful friendship.
Thank you.
Okay, I have a case.
I also found this CACP nomenclature thing. This is from radiographics. So we have switched to CSEP term.
Got it. So we have to put ectopic in there.
Yeah.
Yeah, because it is really high risk. It seems like it'd be a conundrum too. Like, do all of those then get terminated? Seems high risk enough that, yeah. Okay.
It's scary.
Splenic hilum mass.
Right there.
It's kind of encasement of the, oh, there's a,
Pancreas.
body mass, pancreatic body mass.
Okay, so there's two masses. Neither of them is causing pancreatic ductal dilation. Oops. And then there's another finding.
Oh, there's an intussusception too.
With like thickening of the bowel. And something here. And then I'll show you, there's actually a destructive lesion in the bone here that we see better. I'll just show you the MRI findings.
With
So
metastasis.
Similar thing on MRI right here. Here.
Again, you're showing neuroendocrine tumor.
Okay, so you're saying Mets, neuroendocrine tumor.
I've seen myeloma do this.
right there, right there.
What's
And
the age of the patient?
60.
Do you have the, is it markedly diffusion? What's diffusion
Oh, I
look
just want
like?
to show you also, this is the spinal stuff that we barely saw in CT. It is restricting, let's see. And here's the ADC.
Wow, look at that.
Lymphoma?
Yep, yep.
Yeah, you guys got it. So this was lymphoma. It was actually anaplastic B-cell lymphoma, which is a rare, kind of more aggressive type of lymphoma. It originates from T lymphocytes. But it actually has a really good response to chemotherapy. So this patient underwent chemotherapy and is currently in remission. So yeah, just interesting case. First, when I saw this, I was like, oh, the duct is going through it. It's the Guadiana sign, like maybe IgG4. But then like now seeing all these other things, like this was also bowel involvement of lymphoma, mesenteric adenopathy. So it definitely goes well with lymphoma. And then you guys clinched it with that restricted diffusion because lymphoma loves to have really avid restricted diffusion like these findings here. Great job.
Great case.
Elderly person with symptoms of gastric outlet obstruction.
Oh, wow.
Bouverie syndrome.
Yes, perfect.
So there's a eroded gallstone at the region of the duodenal bulb, causing gastric outlet obstruction. And then actually also extending into the hernia, hiatal hernia.
So, as you rightly said, it is Bouverie syndrome, and there's this stone. The stone was crushed and taken out, and usually what we see is there is the fistula between the gallbladder and the duodenum, and the gallbladder stone gets into the GI tract. So this stone has a propensity to go more distally, causing gallstone ileus. Very seldom it goes more proximally to cause gastric outlet obstruction. Now, the treatment for gastric outlet obstruction here will be crushing the stone and taking it out because it's super big. That can lead to gastric outlet that can lead to gallstone ileus, which this patient eventually developed.
Sorry, crushing the stones can lead to gallstone ileus?
Because you can't retrieve all the stones, and then one of the stones actually goes
passes.
distal. Yeah.
Oh,
So,
wow, that's a crazy case. So you have both.
yeah, and the patient came like, I think, 6 days later with obstruction, and then underwent enterotomy, and this stone residue was taken out. Sorry, I'll reword it. Not crushing of stone leads to gallstone ileus. When you crush, you may not be able to evacuate all the pieces. So maybe something can pass distally, and that can eventually cause obstruction.
Yeah, that's a big piece that passed.
Like maybe they should have, like, I don't know, maybe they can go in and take the stone out and do an enterotomy for the primary stone, but I could see how they want to try to do minimally invasive and see if they can pass.
Oh, what about, was there a fistula?
Fistula between gallbladder and duodenum, yes.
What do they do about that?
I think they just leave it. Unless they're already going in for... It's almost like a chronic, like contained kind of thing.
Wow.
Although here it looks like the gallbladder is getting inflamed from, from the gastric
flux
going over. So.
Yeah. I'd take out the gallbladder.
Yeah.
Because you're just asking for some complications later.
Yeah.
From the inflammation.
But I believe it's chronic, so there would be so much fibrosis. Again, I've not seen personally if they take out the gallbladder or what exactly they do. But I think cholecystectomy would be pretty difficult in these cases. But I can read and let you know next time.
Awesome. Thank you.
Thank you.